Good afternoon. Welcome. It's a privilege to welcome our esteemed panel. I I wish we could have done this a week or 10 days earlier, when there could have been a larger group of people from outside as well. But the topic that we are going to discuss today is of great interest to a whole range of people, uh, and including policymakers who are increasingly thinking about some of these issues and which have been highlighted in this kind of work. The problem that this class of studies, which is essentially on the transfer between states, between the center and to the states, are increasingly looking at what is the response that the state governments have to these transfers. Is it leading necessarily to greater allocations, greater efficiencies, or is it perhaps eating into that? And the results are varied, and it's not just in the space of education and health, some of which will be discussed today, but also in urban, which some of our other work at CSEP is showing. So and I'm so glad that Dr. Janak, who had never worked in this space, decided to enter this, and I think it was on Dr. Mohan's doing. I don't think it was your decision. I think it was because he brings in really a fresh perspective. I mean, I've been working in this space for some time, or at least I did in the past. And what Dr. Raj does is brings in a macroeconomist's instincts into this work, and that has thrown up some fresh insights, and some of those I'm sure you'll be presenting today. So I must thank you for doing this work at CSEP. And I must also thank Dr. Sudipto Mundle for agreeing to be here. And of course, Kavita, for finally making it here. It's extremely difficult to get you, and I'm so glad that you could do this. If I knew that I could only get you in December end, then I would have had 5 more seminars. But anyway, that's thanks. So Dr. Sudipto Mundle is chairperson of the Board of Center for Development Studies, India, and serves on the boards of several other organizations. He's also the visiting faculty at the Indian School of Public Policy, New Delhi, and non-resident senior fellow at NCAER. Formerly, he was the emeritus professor at NIPFP. He was also a member of the 14th Finance Commission, the erstwhile Monetary Policy Advisory Committee of the RBI, and the National Statistical Commission, where he also acted as chairperson. He spent much of his career until 2008 at the Asian Development Bank, Manila. Dr. Kavita Rao is director, NIPFP, and holds an RBI chair professorship at the institute. Prior to being the director, she was a professor at NIPFP, leading work on tax policies and assessments of its impact. Her areas of research interest include role of state in the developing countries, taxpayers' perceptions regarding tax compliance, and tax policy design in national and subnational jurisdictions. Dr. Rao holds a PhD in economics from ISI Calcutta, master's in economics from Delhi School. Welcome. Let me also welcome our very own Mr. Amarjeet Sinha, who has a lifetime commitment to work on transforming lives and livelihoods of the deprived households. He is a senior fellow at CSEP. He was the earlier posted as the advisor to the Prime Minister till 2021, looking after social sector and rural initiatives. An Indian Administrative Service Officer of the Bihar cadre, he retired in December 2019 as the Secretary, Department of Rural Development. He has 40 years of experience in the government, largely in rural and social sectors. He has had the unique distinction of having played a major role in designing the Sarv Shiksha Abhiyan, the NRHM, and several other programs. I have a much longer one here, but I'm going to cut that with your permission. Dr. Janak is, of course, senior fellow and leads the macroeconomic segment on the growth, finance, and development vertical at CSEP. He also works specifically on interlinkages between economic growth and human development, fiscal federalism in the health sector, climate finance, and multilateral development banks. He is currently also a member of the JM Financial Center for Financial Research at IIM Udaipur. He has more than 4 decades of work experience, including at the RBI, the IMF, and Ministry of Finance. Thank you. Thank you. So may I now hand over?
Sure, thank you.
Thank you.
Thank you very much, Lavish ji. Can we go to the first slide? So the topic for today's discussion is fiscal federalism and healthcare in India. They are two independent but also related. I will explain to you how they are. So this is going to be the structure of the presentation. I would start with the public spending on health in India, and we would also compare it how public spending fares in India vis-a-vis other countries. This will be followed by fiscal transfer from the union to states and health spending. So we'll talk about both general transfer as well as health specific transfers, that both are important for health spending. And then we had detailed discussion with the six state government officials. They were from Haryana, Meghalaya, Madhya Pradesh, Rajasthan, West Bengal, and Tamil Nadu. So the point 3 and 4 are essentially based on our discussions with them. And then, of course, we'll have also one slide on policy implication, and I will talk about the key takeaways towards the end of the presentation. Yeah. Can you move to the next slide? Okay, fine. That's great. Yeah. So if we see the how much India spends on health, it's just 1.1% of GDP. It was in 2020. That's the year when we had data for other countries. And I had also had a look at the data for 2019. India was actually ahead of Nepal. Of course, Nepal is a very small country. We should not be comparing, but even in 2021, we have even gone back. Nepal has gone ahead of us. So for all the countries we are seeing here, our health spending is low. Forget about the countries like Cuba, Colombia, and Costa Rica, but even other major emerging market economies, they spend much more on health than what we do. This is both in terms of GDP as well as per capita health spending. So how this health spending has evolved in India over a period of time, it's very important to know, because NHM was launched in April 2005. NRH, it used to be called National Rural Health Mission, which later became National Health Mission. So health spending, which was just 0.9% of GDP, of which 0.7% was by the central government and by the state governments, and 0.2% by the central government. It was actually declining. Then comes NRHM, and then it started rising. So NHM played a big role in reversing the declining trend in health spending by states. Of course, there was not much improvement by the health spending by the central government, but definitely there was some improvement in health spending by the states. And of course, there was some pickup in health spending when there was COVID in 2020-21. And it's heartening to know that health spending by states has continued to improve, whereby by the central government, it has come to again 0.3% of GDP. So that was in terms of
yeah. The PMJ and those are
that includes everything. No, this is included. No, that was only that
that the insurance is not a part.
No, health spending, everything is a part.
Everything. This is included.
Yeah, but we are singling out NHM because that was
this also includes the Jal Jeevan Mission spend, water spend.
So it's a major scheme of the central government, but it includes all health spending. Yeah. But if you look at it in terms of state budgets and central government budget, state government spends 5.6% of its budgets on health spending, whereas central government spends just 1.6%. The trend is broadly the same as we had seen in relation to GDP, but 5.6% GDP, we'll see how that too, some states do well, some states don't do well, which we'll see in the next slide. Yeah. So we have given all the states here. National health policy had exhorted all the state governments to have at least 8% of their budgets on health spending. But we are, even after several years, we find that only 4 states are having health spending more than 8% of their total budgets. And many other states have less than 8%, and some states have even less than 5%. And it's interesting to see that last 8 states, Gujarat, Kerala, Haryana, Karnataka, Tamil Nadu, Telangana, Maharashtra, and Punjab, they're all economically well-off states, but they are spending very less on health. So this raises the question, the previous slide, is it the economic resources which determine health spending, or is it the intent of the political leadership? So this basically slide shows this compares the data. We have taken the average per capita health spending and average per capita income, and we have then decided to, then we have tried to see like how each state performs. So we can very clearly see that Punjab and Maharashtra, which are in the high income category, they spend less on health, and many other states like Karnataka and even Tamil Nadu for that matter, Andhra Pradesh, they are in the high income category. They are spending more than what Punjab and Haryana are spending, but they are on the border. But states like Delhi, of course, Delhi is a different case, but you can say Goa, Sikkim, Arunachal Pradesh, they spend much more on health than these states. Of course, there are some states which have even lower per capita income than these states, but they also spend much more on health than these states. So the point is that it doesn't depend on economic resources you have. It also depends on the political intent you have. And we held discussion, I mentioned earlier, when we held discussions with 6 states, most of the states did mention that no, it's not your resources, but it's a political intent which matters for health spending. They also said the resources could be garnered if you have made up your mind to spend on a particular item. So this shows how health has been prioritized in the country by many states. So this fiscal transfers, let me give you a little background of this. These are important for health spending. We have many other countries, not only India, many other countries have vertical fiscal imbalance, in the sense that the revenue raising responsibility of the states fall short of their expenditure responsibilities to balance their budget. Therefore, there is a transfer of resources from the center to the states. This is not the case only in India. This is the case in many other countries. And these resources are transferred from the center to the states based on the recommendation of the Finance Commission, which is a constitutional body set up once in 5 years. Now, 16, of course, Dr. Sudipto Mundle was a member of the 14th Finance Commission. And now 16th Finance Commission is working on its recommendation. So let me point out 2-3 major things here. Number one, the share of states' own revenue, which was in the total, receipts of the states, which was 67% or so, has come down to, it came down to 53.3% in 2023 before it edged up to something like 57% in 2023-4. And the share of all the transfer, general transfers and specific transfer. Now, general transfers are made on the recommendation of the Finance Commission. As I mentioned earlier, they are untied in the sense the states are free to use them the way they want. But there are also specific transfers which are made by the central government. This started sometimes in 2000, I think if I remember correctly, 1950. And so there has been a lot of controversy. While states can have the freedom to choose to spend the money the way they want in the case of general purpose transfer, but there are tight transfer, and there has been a lot of controversy in our country. And of course, the matter had also gone to the Supreme Court and questioning the legality of that centrally sponsored schemes through which these specific transfers are made. Of course, Supreme Court favored in favor of, they gave the ruling in favor of centrally sponsored schemes, but it was considered that central government should have centrally sponsored schemes only if it is in the public interest. So 14th Finance Commission made a strong recommendation that there should be lower role of specific transfers or through centrally sponsored schemes. They gave a greater role to general purpose transfers. So what we see that over a period of time, there has been an increase in both general purpose transfers as well as specific transfers. If you see 22-23, the gap had actually narrowed down between the two. So there was more specific transfers and less general purpose transfer. But I'm happy to note that in the next year, there is some increase in general purpose transfer as well as some decline in specific transfers. So this is significant. Otherwise, if the trend had continued, perhaps it would have totally, merged. So if you talk about the total receipts of the state governments, as I mentioned, there are two kinds of transfers which they get. One is through tax devolution, which are made by the Finance Commission, and another is through centrally sponsored schemes. 14th Finance Commission, I'm repeatedly mentioning 14th Finance Commission are recommended that there should be lower role of centrally sponsored schemes and specific transfers. But we find that there has been a significant change in centrally sponsored schemes. This includes all the schemes, not only NHM, all the schemes it includes. So there has been a proliferation of centrally sponsored schemes and the transfer through centrally sponsored schemes. So if we see the central government share in total health spending by states, there are central government spends on two types of health schemes. One is centrally sponsored scheme like NHM or PMJ or PMOB, but central governments also spend directly, like maintaining of All India Institute of Medical Sciences, also setting up new All India Institute of Medical Sciences, and there is also central government health scheme on which the central government spends. So central government also spends directly. So what we see here is there was a change in the national health after the National Health Mission was introduced of the center's share in total health spending by states, but it has been declining. And now if you see 2022-23, it has come more or less at the same time, at same level, which was there before the NRHM was introduced. So as I mentioned, there are two kinds of interference by the central government on health in the area of health. So while the share of centrally sponsored scheme has come down, but the central government is spending directly through other schemes like called central government schemes. So we can see that when the NHM was launched, the share was 63% or so something. It went up to 70%, but it has come to 46% or so. So 2 points emerge from this, rather three. Number one, there is the role of specific transfers has increased, though the role of general transfer has also increased, but there is increase in the role of more pronounced increase in the role of a specific transfer. Number one, central government is spending more on health. Number two, but that spending is more through direct scheme than through states. So we had also done some empirical analysis. We wanted to know what is the role of health specific transfer, general purpose transfers, and states' own revenue. So this is the model which we used, and the results are very startling. What we found that health specific transfers play no role in spending on health by states, but general purpose transfers and states' own revenue, both were found statistically significant. That means they both play a role. This is for all the states put together. But we get very different results when we split the states into economically well-off states and economically weaker states. So what we find that in the case of economically well-off states, we found the same result as we found in the case of all states, that both general purpose transfers and states' own revenue play a significant role in their health spending. But when it comes to economically weaker states, their own revenue was not found to be significant, but they depend more on unconditional transfer or general purpose transfers. Then we also wanted to, since central government has been spending a lot of money on a national health mission, so we wanted to know what has been the role of this NHM, and we wanted to know whether the states has been substituting their own funds. Like if the central government is giving more funds to states, whether the state governments are spending the same amount of resources in health as they would have spent otherwise, or are they reducing their own resources once the central government is giving more funds. So what we find that all states, if you take all the states combined, we find all the states put together, they substitute their their own NHM spending with non-HM health spending. Let me explain. It means that if the central government is giving money to the states, then states are reducing their own expenditure on health in order to contribute for national health mission. And again, when we take, we divided the states into two different categories: economic well-off states and economically weaker states. And we find that all the states, of course, they substitute, but the substitution effect in the case of economically weaker states was much more pronounced than it was in the case of economically well-off state. The coefficient was almost double in the case of economically weaker states. That means they substitute NHM funding much more than other states do. So as I mentioned at the beginning that we had detailed discussion with 6 states. So next few slides are based on our discussion with those 2 states. Of course, we had collected data also from those 2 states. Let me present some of the slides. So the role of NHM is not only to promote health spending, but also to build the state capacities in terms of not only human resources such as doctors and nurses, but also in terms of procuring medicines, medicine supplies, and also having other equipments which are required for diagnostics and all that, and also training of human resources. So this is the state budget. If you see the state budgets, they spend entirely, most of the funds which states spend on health, they are largely spent on their salaries and wages of medical and paramedical staff. So they have no really resources left to spend on other things. But if we take, yeah, please.
That is there some comparison that we could have, which is an ideal or some, let's say in the private sector, what do you see, or somewhere else?
Yeah, no, we don't have.
Know that that's not the ideal. I mean,
Yeah, but this slides also shows this is the NHM resources. So that was the state's own health spending. So this is NHM spending, and we can find that in this case, states are spending less. Some states spend 50% of their resources on like doctors and nurses, and like Rajasthan spends only 1/3. So they spend on other things like training of their human resources, then procuring of medicines, and getting other equipments. So that shows that in this case, one of the reasons for this is that if I'm correct, that most of the staff which is used for NHM, they are basically on a contractual basis, and they are not permanent staff either, other than Tamil Nadu, which of course then later on I think they take them on a permanent basis, but initially they recruit them on a contractual basis. So maybe this is one of the reasons why they spend less on human resources, less on doctors and nurses. So another objective of National Health Mission was to reduce horizontal inequalities in health spending. So what we have done is basically we have taken the ratio of per capita health spending to the mean to the state level health spending, average state health spending. So the states which are less than average, that means they are spending less, and the states which are spending more, naturally they are spending. So this leads to basically inequalities. So the idea was to find out whether they are converging or not. We covered 29 states, and what we find that only for 4 states have improved their per capita health spending after the NHM was launched. But in one state, West Bengal, their per capita health spending actually declined after the NHM was launched. So the good thing is that all the 4 states which have improved their per capita health spending, they are high focus states. So under NHM there are 18 high focus states which basically have poor health status, and the 60% of resources under NHM go towards high focus states, and only 40% go to non high focus states. So those 4 states have improved per capita health spending. Other states have not. Yeah, please.
State government only, states. It is percolate below that. It is local self-governments. So their, involvement in that matter a lot. Have you reflected in your study that? Their role?
I didn't get, can you please come again?
No,
We'll have a Q&A session afterwards, if you don't mind holding on. Let him finish his presentation. Otherwise he'll lose his, train of thought. We'll come back, have a Q&A session. Yeah, please
Okay.
carry on.
So again, this is based on our discussion with the state governments, 6 state governments, and two major things which came out after detailed discussion with them. One, many state governments are unhappy that they have no flexibility insofar as NHM is concerned. They say that central government forms the scheme and it is implemented by the state governments, and many of them complained that they were just implementing agencies because they had no ownership in the scheme, because states were not consulted when the NHM was launched. And they had no flexibility. If you see that chart on the right hand side, it shows that most of the resources are spent on basically maternal and child health care. But different states have different priorities. Take, for example, Kerala and Tamil Nadu. I think in Kerala and Tamil Nadu, their population is aging and they want to devote more resources towards the taking care of elderly population. But they said they have no room to maneuver when it comes to NHM. They have to necessarily spend that most of the money on maternal and child health care. And the second thing is that many states felt that they don't get resources from the central government in time, and there's a lot of uncertainty when those resources will come. So these are the two major constraints which state government expressed to us. But the question is, how do they cope with these constraints? So it's not that state governments don't have flexibility at all. State governments do have flexibility, but flexibility is very limited. And I've given the quotes of some of the state government officials. What emerges from these quotes is that if you are able to show some good results, central government does allow them to use those funds differently, but the room to do such things is very limited. And insofar as funding is concerned, if the funding from the central government doesn't come in time, then they use their own resources. Actually, in the case of Meghalaya government, they have set up one corpus. If the state government funding, if the central government funding doesn't come, then they use those funds. And then once the funding from the central government comes, then they adjust the funding from the corpus. So what are the policy implications for our findings? One, we feel that when it comes to transfers, general purpose transfer from the central government, there is a need for a greater role of general purpose transfer, and we have found a welcome change in 2023-24, as I mentioned I showed in my earlier slides. But there is a need that this to persist with this trend. That's number one. NHM has certainly played a big role in strengthening healthcare services in the country. But the issue is that it can play a much greater role, provided the state governments have much more flexibility in using the funds under NHM the way they want. I'm not too sure whether the state governments can be given 100% flexibility, but definitely there is a greater room for state governments to have more flexibility. And then since some state governments, they substitute NHM spending with non-HM spending, they need for some change in the incentive structure to ensure that state don't substitute their own spending. Because if the idea is to promote health spending, then we need to ensure that whatever resources are given under NHM, they are spent. And then states also spend the same amount of resources had they spent otherwise, had NHM been not there. I also feel that they need for much greater focus in case of economically weaker states, because we found that they are substituting much more than economically weaker states. If we want health spending to improve, we need to pay special attention to economically weaker states, and then we also need to ensure that they get their funds in time, because rich states could economically, I shouldn't say, economically, better states could manage their resources, even if the funding is not coming from the central government, but economically weaker states are not able to do that. So I'll just quickly run through the key takeaways. Health remains a very low priority in most states, which you have seen. NHM has helped reverse the declining trend of health spending and help build up state capacities on health. State dependence on transfer from the union has increased vis-a-vis their own revenue, but this needs to reduce. Economically well-off states depend more on their own resources than unconditional transfer from the union for health spending. Economically weaker states depend solely on their on unconditional transfers. So that shows that unconditional transfers are important for them. All states substitute health spending with non-HM health spending, and the substitution, in fact, as I mentioned before, that is much pronounced in the case of economically weaker states. Some evidence of, we find, as I mentioned earlier, 4 states have been able to increase their per capita health spending, but of 29, only 4 states have been able to do. But of course, we need to put much more efforts to do that. And the 2 constraints which states face, and one is of course lack of flexibility, another is fund flow challenges. And I would stop here. Yeah. I request Dr. Sudipto Mundle now to please give his comments here.
Yeah. Yeah. Okay. Thank you, Janak. That is a very comprehensive and very insightful presentation you made on health spending and federal transfers and so on, based on the work that you're doing. And as he was mentioning, that you bring a fresh perspective since you're a central banker.
Yeah.
Now doing something else, which is very welcome. I'm not going to comment much on his presentation, because I'm sure that Amarjeet and Kavita will go into the details of that. I might incidentally touch on a couple of points he made. But when he asked me to chair this, he raised 2 questions for me to comment on, and that's what I'm going to take my few minutes on. The 2 questions have to do with the centrally sponsored schemes. As he mentioned, there have been a lot of criticism, particularly from states which are governed by parties which are not in power of the center. About centrally sponsored schemes, the fact that they don't have any flexibility, etc., which he was mentioning. That takes away from the state space in terms of, public expenditure policies. And the other question was about the increasing use of cesses and surcharges by the central government. He did not talk much about this, but I'll come to that. This has indeed happened, especially since the sudden increase in the share of devolution from the 14th Finance Commission. But before I come to these 2 particular issues, let me make a couple of general points to set the context. We think that we have a federal government, but actually we have what is more appropriately described as a quasi-federal government. Because when the constitution was created, there was a lot of concerns at that time about potential fisciparious tendencies and so on. And the fathers of the constitution, they left residual powers and so on always with the central government. And on balance, the central government has had much more power vis-a-vis the states. There's, as you know, the 7th schedule, which indicates what are central subjects, what are state subjects, what are concurrent lists, and so on. But always at the end of the day, if there's some conflict, the residuary power for the final word is left with the central government. So that's one point. The other is that on the question of fiscal decentralization, there is a tension between 2 opposing forces. One is the principle of subsidiarity. It is very well known that if you push down the decision making to the level at which the particular jurisdiction the decision is being made. So in other words, decisions being made to cover the jurisdiction of a state are best made at the level of the state government. If it is a decision which will only affect the panchayat or the urban local body, then best to leave that decision to that level of decentralization, because they are much better informed with the details of local conditions and so on. So that's the principle of subsidiarity, that the priority in decision making is given to that lowest level jurisdiction, and what is left over is then left to higher levels of authority. Now, this principle of subsidiarity is in conflict with a completely different, opposite principle, if you will, which makes the case for centralization. And what are those? One is, of course, externalities. When you have decisions being made which have spillover effect across the boundary of a state, obviously that decision making has to be done at a higher level. And you can think of, there's of course the pure public goods case. I mean, something like defense security, you can't devolve, you have to leave it to central government. But beyond that, say your national road network or national power grid, national gas grid, and various such infrastructure things, also you need to have a central government making those decisions. But beyond that, coming more to social spending thing like on education and health and so on, as Janak mentioned, there are issues of national interest. You do want to make sure that people belonging to the same country, to the same, if you will, tax regime, the same common market, etc., that they have access to the same level of public services, at least the funding for potential delivery of public services. Why should somebody living in Maharashtra be better served on education and health than somebody living in, let us say, Bihar? They are paying the same, same kind of taxes and so on. They should get the same. So that's another thing. And then the issues of national interest. I mean, you want to make sure that people are not starving anywhere in the country. You can't just leave it to the states. You have to make sure it's a national interest. You want central government to intervene. And then there are also questions of, economies of scale. There are some things which are best decided at a high level jurisdiction because of economies of scale. So there are 3 or 4 issues which militate against decentralization. You want to centralize for those reasons, but subsidiarity says you should decentralize. So there is this tension. The 7th schedule at that time, when the Constitution was constituted 75 years ago, came out with a division of responsibilities, which at that time they thought was appropriate. There have been a lot of rethinking about it since then. There have been cases made that you should revisit the 7th schedule and perhaps redistribute some of these subjects and so on. So this is by way of general background to the 2 questions that Janak wanted me to address. First of all, on centrally sponsored schemes. There has been a lot of pretense of reducing the number of centrally sponsored schemes. But there's a bit of a fudge over there, because all that has been done, if you have 100 schemes, you recombine some of them and reduce the number to 60 and then reduce them to 30, but actually not really giving up anything because you're just aggregating them in a different way. So we do have a whole lot of centrally sponsored schemes. And one of the reasons why the 14th Finance Commission did not really go much for giving grants and so on is that the amount of these grants is so small compared to what an individual state actually spends, that it really wouldn't make much of a difference, and much better to just support the state's access to resources in general. But that being said, as I said before, for some things like education and health, you do want to make sure that a citizen of India, whether that person is resident in Kerala or in Delhi or in Assam, should have the same access to the same level of public services, because they're part of the same common market, part of the same jurisdictional taxation wise and so on. So that has been one of the strong arguments for centrally sponsored schemes, particularly in the case of health, which is what we are discussing today. But that being said, there is nothing that prevents you from designing a centrally sponsored scheme, which leaves enough flexibility for a state like Kerala to address its priorities, aging population, etc., as compared to a place like UP or Bihar, which may have different priorities. I think that those can be built in to the centrally sponsored scheme. Amarjeet has been involved in this, and hope you will address this issue of whether this can or cannot be done, how it can be done, and so on. And a second aspect, of course, it is certainly an issue that if you release the funds, what is being transferred from the center, in the last quarter of the year to a state, then they're unable to really use those funds properly, and then they just push out the money in some way, except in the case of the better off states, as Janak was mentioning, where they have a buffer and they can use that properly to spend the money, and then it gets substituted when the money finally comes. But the poorest states like Bihar or Odisha or UP don't really have that luxury. So subject to these things, the centrally sponsored schemes should be done in a very limited way where they meet these particular objectives I mentioned. Otherwise, you should do away with them. Do away with hundreds of schemes, have a few which really are important to have them at the national level. Coming to the second question of cesses and surcharges. Constitutionally, cesses and surcharges cannot be part of the what is known as the devolution package. All other taxes can be progressively over various finance commissions, more and more taxes have come. Now all taxes are actually shared except cesses and surcharges, and that is not possible constitutionally. So what the central government did following the 14th Finance Commission award was to increasingly rely on higher and higher cesses and surcharges. And the share of cesses and surcharges in the total revenues of the central government started going up. Now, this was clearly directly undermining the spirit of what was recommended. I have to say that if I'm not mistaken, in the last budget, the finance minister did not do this. She did not raise the share coming from cesses and surcharges. Kavita, you may have more detailed information on this, but that's my recall. So I'm very glad that she has stopped this business of progressively.
Yeah, no, you're right. The share of cesses and surcharge in central government revenue receipts has come down in the last.
Yes, in this last budget.
Absolutely.
Yeah. So that's a very healthy development. But in general, I think this was a very unfortunate, this undermining, and we need to think about, because now we have somebody behaving sensibly as the finance minister, but tomorrow you don't know who will come and what will happen. So if there's a way of institutionally ensuring that this does not happen. So these are the two comments I have in response to the questions. I don't want to take more time. I'm sure Amarjeet and Kavita will deal in detail with the very good presentation of Janak. Thank you.
Thank you. Thank you very much. May I request Amarjeet?
Kavita ji, Sudipto ji, and Janak, dear friends. Thanks, Janak, for your presentation. I have a little problem, and the problem is I am too directly involved with the National Rural Health Mission from its first page to the last page.
Okay.
And thereafter, in 2010, as a member of the high-level expert group on universal health coverage, which Dr. Reddy headed. So some anecdotes I'll try to relate only to say how policy is formulated. Does anybody know why the National Rural Health Mission came in 2005? Any of you? Yes? Yes?
They suggested we have the Commission of National Council and Health.
Okay. Now, if I were to add a slightly personal twist on this, Dr. Manmohan Singh, between the time he was finance minister and became the prime minister, was in Geneva with a development research institute. Not many people know one of the papers he wrote at that time was on health. very categorically, day one that he joined, Mr. BVR Subramaniam, the current CEO Niti Aayog, was PS to the PM. My term in Delhi was over after SSA and other works in Delhi. I was packing up to go to Patna. He comes to my residence. Don't send your luggage to Bihar. You have to work for the National Rural Health Mission. My late colleague and very dear friend R. Gopalakrishna, who was in the Prime Minister's office at that time. So the two of us were mandated to do the detailed costing. Now I come to what you mentioned. Now these are not that were prepared in the air. The National Commission on Macroeconomics on Health had made some projections. Very clearly, it had projected 2.5 to 3% GDP public expenditure. The framework for implementation, which is there, it provided for a 10-fold increase over the 7-year period in the allocations of the central government. And this is not something which was a department's wish. This is approved by the cabinet. The cabinet formally approved the framework for implementation. We refused to take it without these details. In spite of it, it was only in the first 4 years, 2005, 6, 6, 7, 7, 8, and 8, 9, where we managed to fight and get the resources that were due to us. Some early results. Now, again, how do you push good policy? One very good example, when you talked about consultations, I just wanted to share with you. Gopalakrishna and I had done a lot of homework. We made a presentation to Dr. Manmohan Singh, and his suggestion was, while this is very good, but why didn't you get the top experts from all the sectors, private, government, wherever, 16 committees on health, let them make their recommendations. And your framework for implementation should reflect the consensus. That's what it did. It was a clear commitment to public system of healthcare. We have no hesitation in saying we are not defensive about it, because there was no public system of care. Now, what is it that did not work thereafter? What happened? And so in terms of the institutional structure, every major policy call requires quick wins. We had a few quick wins. We had an advisory group on community action where the best of the civil society was engaging with us. We had states as members of each of the committees that formulated the document. There is, you can look at the framework for implementation. It is the most flexible document you can think of in the first 4 years. Reason for it was, Kerala, for example, never spent a rupee on their health sub-centers and primary health centers, because in Kerala, the health-seeking behavior is such that even to immunize a child, the parent wants to take them to a sub-civil hospital, a pediatrician to do the immunization. That's their current position. Tamil Nadu, on the other hand, used National Rural Health Mission to convert every 6th primary center into a maternity home. Whole lot of innovations in human resource engagement, appointment of nurses, paramedics. Now, one of the principles that began with the Sarva Shiksha Abhiyan, so I'm a culprit for many programs, because even with the Sarva Shiksha Abhiyan, before that we had something called Operation Blackboard. You may ask, why did we do these sector programs? What was the necessity of large centrally sponsored schemes? Under the Operation Blackboard, which provided the second teacher to schools which didn't have the second teacher, the position was at the end of the 5-year plan period, all the liabilities used to stand transferred to the state government. The Finance Commission awards were not coterminous with the central plans, 5-year plans. As a consequence, now many states, they availed of the Operation Blackboard in the 3rd year of the program, only to start paying full salary of those fellows by the 5th year. Nobody was willing to take it. So we came up with this principle of sustainable financing. And in that principle of sustainable financing with SSA, we said, okay, 2000 to 2004-5, we will provide 85-15. We said thereafter it will be 75-25, including HR costs. And thereafter it will be 65-35 and finally settle at 50-50. But all this was contingent on allocations going up. We had our fights then also. Policy in education, Dr. Tapas Majumdar, the late great economics of education man, I was his member secretary. We did a normative costing of education. And we said, you can't do with anything less than 1,36,832 crores additional funds over 10 years. When the matter went to the cabinet, the then finance minister, Mr. Yashwant Sinha, threw up his hands. Where will the money come from? The proposal was returned to us, and Dr. Murli Manohar Joshi was our minister. So 9 education ministers sat together again. Instead of a teacher for 30, we said, okay, do it for 40. All I'm trying to say is policy making, there's a lot of pragmatic shifts, not necessarily recommended, but many a time it has to be undertaken. So we had to make, because so finally when we went the proposal of SSA, then also we asked for 60,000 crores. Then also there were hands being raised, where will the money come from? The late Prime Minister, Mr. Atal Bihari Vajpayee. I still remember when objections came from cabinet ministers, the response of the Prime Minister was, "Bachchon ka mamla hai, chalne do." And that's how it got cleared. So many a time it is a touch and go when it comes to public policy. Now, what did NRHM do? If I look at the indicators on infant mortality, maternal mortality, fertility rates, hospital functioning, number of patients coming to government facilities, access to health facilities, I will make a mention of this because the case for giving more money was very strong. Unfortunately, the Planning Commission, as also the Finance Ministry, was an obstruction. I use the word obstruction because we had to, no, we'll get a study done. Let the study tell us whether or not this is working. We explained that attribution is not so easy. It takes a little while. Give us a few years to implement it. Then only you'll be able to see the results. We started when infant mortality rate was stagnating at 60 plus. Today it is 25. We started when the maternal mortality ratio was 409 for every 100,000 live births. Today it is down to 97. Total fertility rate was at 2.7. Now it is 2.1. Why I am mentioning these figures, something did work. Some of the principles of decentralized planning, and again, a lot of the grants which went to states, state governments could not spend. It had to go to the primary health center as an untied grant. It had to go to the health sub-center as an untied grant. It had to go to the district health action plan as an untied grant. The intent was the institution whose doctor I am asking to improve the facility, he must have the control in his hands. You ask him to keep your hospital clean and he has not 1 rupee. How is he going to do it? So this was the principle. This just to build credibility. Besides one, of course, we had a very strong technical support group, both in SSA and in NRHM. The National Health System Resource Center with Dr. T. Sundararaman, Srinath Reddy and others, who would guide us on technical parameters. We also had a regular system of common review missions like bank projects, both for SSA, NRHM, and later in the rural development sector also. Only we did this one because and the common review missions had state government, they had central government employees, they had university employees, they had civil society representatives. When they said that something is working right, everybody took it seriously. So quick wins are important for any program, but the unfortunate bit, till 2009, it was steady. Some setback happened because UP started very well in the first 4 years. In the 5th year, I'll not name the person, somebody 2 years my senior, he decided to take the mission for a ride. And he managed to get away with it. He was languishing in jails for many years. But having said that, UP also had done outstanding work in the first 4 years. Mr. Rajiv Kapoor was there at that time and outstanding work they had done. But clearly with the NRHM scam in UP, it created bad blood for the NRHM. But across political parties, like with SSA, when the governments was changing, when Vajpayee's government was changing, people said, "Ye UP वाले तो SSA को निकाल देंगे." किसी ने नहीं निकाला. NRHM जब जाने लगा हुआ कि government change हो रही है, अब क्या होगा? Nobody threw it out. In fact, the Honorable Prime Minister, as Chief Minister of Gujarat, made full use of the National Rural Health Mission to build up the infrastructure for hospitals and health facilities in Gujarat. Many states like that. So clearly, policy making, financial resources. So the idea of a large sector program was, and again, it has a lot of flexibility. I gave the Kerala Tamil Nadu example. I can give many more. The horizontal transfers that you mentioned, that's where we feel we could have done better. We applied a formula called 1:3, 1.8. The formula was that in the case of developed states, which is the non-18 high focus states, we'll give them resources as per their population. In the case of the 18 EAG states, Bihar, UP, Madhya Pradesh and all, we'll multiply the population by 1.3 to be able to give them a little more money. And in the case of northeastern states, we'll multiply by 1:1.8. Assam got a lot of money because of that. If you go to Assam, it is a transformed state as far as health infrastructure is concerned. So clearly, a lot of things worked. But what didn't work was for both the programs, there is a certain financing from 6,500 crores in 2005-6. We were to get 55,872 crores in the 11-12 year. What we got were abysmal pittance. This study, that study, in spite of putting the evidence that it is working, we need more. When we pushed very hard, first we had Kaveri Gill doing a study to find out how NRHM is doing in 2009. Then we had the Srinath Reddy committee, of which I was also a member 2010, the universal health coverage. We hurriedly did our full evidence-based report thinking that something will happen. 2011 we submitted. It never saw the light of day thereafter. So clearly, people at the helm, while Dr. Singh was supportive in the beginning, now later when it became National Health Mission, again, the problem is that the urban areas have been shortchanged. No additional financing has been provided. Very nominal financing has been provided. So the situation in urban areas, as many of us noticed to our this thing in COVID period, we had better teams in the rural areas to do vaccination than in urban areas. And main reason for it is that for a 50,000 population, you have something called universal health post. It doesn't work. It doesn't work as effectively as it ought to be. So the infrastructure strengthening project, which was approved after COVID, 63,000 crores is what was said. But we find most of it, again, is showing the Finance Commission transfers as part of that program. So it is not additional money. So I think the point I wish to make, and when you're recording the increases in allocations, two things. One, of course, PMJ has led to additional resources. The other, which probably you've not factored, is the fact that water expenditures, Jal Jeevan Mission, when you are doing a lot of the infrastructure for Jal Jeevan Mission, even that is being reported as expenditure on health. So once you account for it,
we excluded that. Yeah.
so the centrally sponsored scheme was not the ideal solution, but it was, as I said, a sector program. In fact, the support we took from the World Bank for SSA was also a sector financing program. They did not get into the nitty-gritties of it. We said, this is the overall sector program for elementary education, either support or don't. So they also came in to support us on this. But having said that, there are some incongruities which creep up in centrally sponsored programs, which goes on for a very long. Central sector in health, I am a little worried because that is expanding and may not necessarily be the best thing to happen. The management structures of All India Institutes of Medical Sciences must have a bigger role for state governments. Clearly, like the IITs, there is a IIT Act which determines how IITs are run. This was a suggestion I had given to Mr. Ghulam Nabi Azad when he was the minister. Like IIT Act, we should have an act for the AIIMS as well, so that there is a transparent system by which you manage the institutions. Otherwise, in the course of just doing central funding 100%, these are being seen as major infrastructure projects, but the subsequent development of human resources and other things, that may well better if we were partnering with states more effectively. So I think these are some of the points that I thought I'll make. Thank you.
Thank you very much.
Thank you very much.
We request Dr. Kavita now to give
Can I-
comments.
Is it okay if I speak
Yeah,
from here?
please. Yeah.
But you use that, I think, the recording.
I am.
Oh,
Okay. Thank you very much. Very interesting paper. Asks a couple of very interesting questions. And I almost dislike speaking after both of them because whatever I say is going to sound terribly boring, but I will say it all the same. Yeah. So I'll start a little bit by just looking at the paper itself, and therefore what we can draw from the paper. And there are 2 or 3 different things that I think are of interest coming out of it. First question is, do states have enough resources? Are they becoming more dependent on central government transfers, devolution, and grants? It can be seen, I think, in 2 slightly different ways. One way of looking at it is to say that central government's revenues have been more buoyant than the revenues of state governments. And therefore, whenever the center is transferring a certain fraction of the revenues to the states, willy-nilly, this becomes a larger component compared to the state's own resources. And that brings us to the question of whether this is a good idea or a bad idea. Given that the constitutional assignment of tax powers does give the center a larger number of more buoyant sources of revenue, it is expected through the devolution process that center will transfer resources to the states. So in terms of tax devolution, do we visualize it as being dependent on the center? Do we visualize this bucket of resources as being states' own resources? That distinction, I think, is very important. It is now coming to cloud how we look at GST as well. If you look at, if you speak to people from the World Bank, for instance, now they're questioning whether GST, state GST is state's own revenue. And that, I think, is a problematic position to be in, because there are two ways of thinking of own source revenues of states. One is what they have the right to change and to collect themselves. The second is anything on which the spending decision is all theirs. Both, in a sense, are resources of the state. And by trying to look at only own tax revenues and own source revenues, we are undermining or underestimating the amount on which the state does have control. So that's one small limited point on how we want to look at the composition of revenues of states. Second, from there is also to ask, if you're looking at state expenditures, do we necessarily, and this is from a health sector, given the fact that you mentioned Tamil Nadu is not exactly spending large amounts, does large amount necessarily mean better services? And there we might have a slight problem, because states like Arunachal Pradesh, states like Sikkim have very small population size. The population is distributed over a very large area. So the per capita expenditures might actually be higher, not necessarily implying better quality of services. So there may be a slight de-link between expenditures and quality of service, which we might keep in mind. Tamil Nadu in particular, I think, is an example of being able to provide reasonable quality with lower cost compared to other states, from what my colleagues in health studies tell. Similar, I think, is a statement being made also about Karnataka at being able to provide good quality of services at more reasonable costs than compared to Andhra, for instance, where I'm told the costs are much higher. So the cost to quality of service, the connection may not be straightforward. Then coming to what's the impact of NHM, NRHM, and the introduction of CSS on states' expenditures are. It's an interesting point to make that if you keep NHM out of the total expenditure net of NHM, you find that increase in NHM is equivalent to, has a negative impact on expenditures. NHM, if I'm not wrong, underwent many avatars. It started off as a 100% Government of India program, then it shifted, and at the moment it is now a program where states have to put in a part of the expenditure, the resources, which effectively means that if states have to utilize the money being made available under NHM, they will have less available to do everything. That might be one thing to keep in mind when we are talking about the substitution going on. The graph that you had one graph which shows that expenditures went up after NHM, NRHM, and then they came down, center's contribution. Does it, empirically, would there be a structural break at these 2 points? And therefore, empirically, if you're estimating the model, should we be looking for some structural breaks?
Yeah, we did, but we can test that.
Yeah. And similarly, empirically, would you like to think of NHM as a natural experiment, and therefore you start pre-NHM and then do a check for a break there as well. Yeah. Similarly, to be able to compare coefficients across groups of states, it might be useful to nest all of them into one equation instead of doing multiple equations, because then the coefficients will be comparable. It's just a suggestion on whether that will be, that provides you the basis to say that's for certain states, the coefficient is much higher than for other states. So that is, that was also the reason why I was thinking of you give a coefficient for 2005 to 2014 and another for 2005 to 2019.
Yeah.
So if we could see if there's a structural break there, dummy there, it might tell you whether the two regimes are different. And that helps you tell the same story in a neater way. Going back to this overall question of NHM being a CSS, and what is it that we would like to see the center to be involved in? Taking off from what both of them said, my I think as a concern is how do you build this, how do you build a framework where you have flexibility and you have central commitment? Can we think of every state, for instance, having a strategic plan? We don't like the word plan nowadays, so we can find a different word for it. But can we have a medium-term perspective for each state, which is different for every state, which requires capacity building in the states to be able to construct their own medium-term plans? And then there can be endogenized metrics for monitoring progress. And Government of India can choose to support each of these individually instead of it being a well thought out, broad program, which yet will address only certain concerns. I think in a lot of centrally sponsored schemes, we might have to go down that path of trying to explore how states can articulate their needs and their priorities, which also allows for the possibility that health is not a priority. Why I say that is we are all asking states to collect more revenues. Does the state have the ability to choose between physical infrastructure and health? The payback time, if you can think of a payback time for education and health, tend to be much longer gestation lengths, whereas physical infrastructure might have a shorter gestation length. If I'm trying to push up my economic growth in order to get to higher levels of per capita income, which will allow me to collect more taxes, which will allow, does the state have the space or the need to prioritize? And then therefore, would it necessarily put health at the top of the bucket for all? And that may not. Why is this a concern? Because if you look at per capita own tax revenues, per capita total revenues, the difference between Goa and Bihar will be like 10 times. And in that 10 times difference, there is no way you can find resources to do the same things everywhere. So then Bihar has to prioritize. Should it invest in creating economic infrastructure for growth, or should it create education and health so that 10 years down the line, people will be better equipped to be entrepreneurs and create economic growth? There is a trade-off. And I don't know how we answer this trade-off question, but I think that trade-off is sitting front and center for all of us to address. And there is where the center needs to come in to say everybody can't spend. So as Dr. Mundle said, every citizen has a right to a certain level of health. So can we construct state-specific health plans, which then allows the state to have a target of what they want to achieve, and therefore come to a situation where they'll seek to achieve it. I think in the context of the 15th FC, the other additional dimensionality with health grant that's emerging is that states, the funds are meant to go to local bodies and not to the health department. the finance department, the health department, the local bodies, the PWD. There are so many departments which have to talk to each other to make it happen, that utilization suffers. So conditionalities and structures sometimes help spending, targeted, but sometimes create the window of opportunity where utilization doesn't happen. So do we know the right way for every state to go forward? So I'll stop there. Thank you.
Oh, thank you.
Thank you so much.
Thank you all for making this wonderful comments. We have 15 minutes, but before I go to the audience, just one question to you only, Amarjeet ji. And I'm picking up the thread from where Dr. Kavita Rao left. Like, I can understand that Bihar not able to spend much on health because they don't have resources. But what about the economically much well-off states like Punjab, Maharashtra, Karnataka, Tamil Nadu? Why are they not able to spend much more than, like, even in their case, we found that they're spending less than 5% of their total budget on health, whereas some states which are not so well off are spending like 6-7%, forget about 8%. Why is it so? And whatever discussion we had with the state government officials, they were all said that it's all driven by political leadership. So it shows that states which have resources, if they're not spending, perhaps it's not a priority for the political leadership. So what do you?
So I
see
can
this?
tell you that the initial years of NRHM,
Okay.
Bihar, UP, Madhya Pradesh, they were the top performers. The so-called high EAG states, Vardha, Rajasthan, did some very good work, from the 108 ambulance to a whole lot of other things. But if I'll check the figures again, overall spend on health, not this distinction of NHM and non-NHM, overall spend on health in Bihar has gone up over the last 20 years, quite significantly. Having said that, the problem is that 1.3, 1.8 that I mentioned, it does not settle the issue. The more we looked at the health sector, today, for example, in all my recent writings, I've been recommending what Kavita ji just said. Can we work out a normative costing of what it will take to provide quality primary health care in Tamil Nadu or Bihar or whichever state? And whatever the gap, can there be some arrangement where the central, state and local governments decide on the next 5-10 years what they would like to do? I give the example of Brazil. When Brazil introduced the universal primary health care, it did so fully recognizing that local government, provincial governments and national governments have to make available a certain sum of resources year on year. The agreement was for all the 3 levels of government to commit over a 10-year period on what the allocations will be. And it got the results that it wanted. So clearly, I think federal principle is important, but the federal principle has to work effectively, because clearly a lot of the new innovations in any state sector does not happen with state resources, because they're always stretched because of salary payments and other requirements. These are all high HR sectors. You have high population, you have high health burden. So naturally, the pressure is always very, very high. But I will check the figures again. I have seen it about 20 days ago. Bihar's expenditure per se, not the distinction of NHM and non-NHM, has gone up almost 35 to 40% over the last 7-8 years.
Per capita basis.
Per capita basis. Because they have gone in for medical colleges in unserved area. It began from the very basics actually. It didn't have medical colleges in more than 70% of the state.
Okay.
So a lot of the major investments have happened there also, but I'll give you the updated figures. Okay. So there was a lot of enthusiasm in the states. When we started it, not one state was defaulting on the state share. Likewise, in the PMGSY, or the PMAY Gramin, or the Sarv Shiksha Abhiyan, no state was defaulting on all this. But ab problem kya ho gaya na? Lot of the additional HR that we've engaged, NHM, because the allocations have not gone up, it should have been 90,000 crores in central government every year by now. It is still at 36,000 crores. So of which committed expenditure is 34,000 crores. So where is the money for innovations? The HR that you already engage, all you are doing is continuing to support that. So it has become a mess of the program. If you don't raise the allocations as per what the original plan is, then naturally there's a problem. We need to increase much faster. And this fragmentation of, this will go there, that will, it doesn't help. There has to be a comprehensive plan for primary health care, which all three sign on.
Okay.
You had a question.
Yeah,
in the
we'll
beginning,
first
but
give
you
you.
have to
Yeah,
respond.
please, yeah. No, I couldn't get your question. Could you please repeat your question again?
Oh, Mike,
Thank you very much, sir. I have two purposes to come here. One is to learn from the presentation. Another one to meet Sinha Saab because I work with him and I was the Ministry of Rural Development. And Bhandari Saab because we are when I was the Ministry of Panchayati Raj, so we have interacted a lot. No, I just wanted to say that in a debate of federalism, we must also include the local government, both in urban area, rural area, because they have own, system of governance, and they have their own resources to mobilize. But generally, what is happening that 10% is they are mobilized generally, with some differences here and there. So that would also be put into the discussion as a government. Second, that what I came to know from this discussion, that is we have to see the things in integrated manner. An integrated manner, as Sinha Saab has said, that in a local level, that is district planning committee and other local level committee, and that has to be given a proper infrastructure, proper manpower, proper other facilities, technical things. Second thing is also important as a practitioner, that the pupils' participation. When I was in the planning commission, then planning commission, that we talked about model. Fine, they have their role, but the model is more important than model is the pupils' participation. Whether the community is really know that their responsibility, whether they are involved in that or not. I have been reading a number of papers in the Hindustan, the community involvement Sinha Saab has written. We have also written. So the community participation, participatory planning. In Kerala, I used one example in my own book, that if suppose resources are not there, to other states again we don't have resources. But the Kerala local self-government said, okay, we have the resources, we will pay this thing. So such type of participation very important. Another important thing that I think is that sanitation is not talked about. A lot of resources have been transferred to local government. So what is the role of so many resources involved? Even 14 Finance Commission even not given money to the intermediate next year, only devolved to the Gram Panchayat level. So how this also have an impact at the local level. So I just wanted to say.
No, thank you very much for raising the issue of local governments. This study, we of course didn't cover local government because we had constraints, but we have plans. They're very important. Of course, I agree with you. Whenever we talk about fiscal federalism,
Yes.
we just talk about central and the state government. We forget about the local governments. So we have plans to take up, studies even on the local government, and of course, the local participation, the issue which you have raised again is very important. People should be actively participating, and they should be aware of if there are programs, they should be benefiting
They are
from
not
those
aware.
programs. Yeah.
But they are not aware. I am living in a village, Western UP. I
Yeah.
know that there is no Gram Sabha, no meeting, no Gram Panchayat meetings. So what is going on?
You'd like to add, Amarjeet, about the local
Nothing at this
part?
stage. We are like to have other questions.
Yeah. Yeah.
I have two questions. When I interact with people in the state governments, especially, I have some experience interacting with people in MP and Rajasthan. There's almost a kind of a, health department really kuch bhi nahi kar sakte. Almost as if that they've given up because of the lack of capacities within their own, within the whole, within the government itself. Now, the question is that instead of trying to have whole programs designed from the center, if we flip it and just had center focuses on capacity building of various types, both of medical personnel and the managers and the administrators and so on, would that at all be a feasible this thing? And that ties me to the point that you had made that, prioritizing It sounds so easy to do, but none of us have done it. The issue of trying to have state level prioritization, etc. Now, you must also have tried it. I mean, what are the challenges that you might have faced in trying to do that kind of an analysis?
Then before you answer, I just want to throw in, as was implicit in what he was saying, that we can think of prioritization on some rational basis, but that's not how policy gets made. His politicians and his decisions, priorities, his in his head is ultimately what makes the decision. But before there are a few other questions. I think the gentleman just behind you, you had a question? Collect a few and then.
Yeah, sure.
Thank you for your wonderful presentation. I just have few comments, maybe. So first one is that one way when we are looking at the indicator is primarily it's kind of a ratio of percentage of health expenditure, right? But this doesn't, one of the reason which I feel probably why the more advanced states as far as economically concerned are having less expenditure is because maybe they are already have built up on their capabilities. So they don't need to, invest more on the hospital side as probably the other state which are economically weaker. So can we take into consideration the initial stock of health facilities or infrastructure into the account, and that can probably, give us some sort of. Other thing is that I think since I am from Punjab, I feel that some of people may not feel, comfortable going to the government hospital. They mostly will like to, because they have money sources, so they probably will go to the private sector for their thing. So can we say that how much percentage of people are being, catered in these states from the domestic or government side? That may also, try to, clarify some sort of biasness. Other thing I would like to say is that, every state, like ma'am has already said, have a different kind of, need for the health. So some of them, like say Odisha, may be having more of, mining going on over there. So they might have a different kind of, requirements, which may be like air pollution or something like in Delhi. But some of them, like Punjab, may have, other problem because they use too much chemical. They have some problem like cancer and all. So the cost will vary for that as well. So can we say, I mean, it's very tough, although I'm just saying that, can we divide some states into groups based on something like geographical or population density? And then, or probably in that way, it will be easier for, like, rather than comparing all the states into one category, it will be little bit injustice to that. Other thing is that big states like Maharashtra, probably they will go and use the same hospital across there are 2-3 villages, but they will go to only one hospital. So that will be like economy of scale which they were talking about. So that may be also be considered, that what is the how many per patient per day being addressed by those. So that can give us some sort of a stress on the assets. Those are things and other thing is that there are something which I have also worked on some parliament report on CSR. So there I found out that majority of the the intervention done by the companies are also on health as well. So if let's say a backward area which already has been taken care by, let's say, Tata, then there is probably no need for government over there to come and do another intervention, because that's just crowding out. So can we see which are the key areas of CSR interventions, and or maybe a kind of a where private people are already going on helping it out? So that we can try to further refine our formula for which states need more things. So these are just small things. I have some, but I don't want to hog the time.
You have already raised many questions.
Yeah. Any other before we come? Yeah, please go ahead.
This is a clarification questions. I just want to ask what econometrics techniques did you use for your empirical analysis? And since it's a panel data,
Yeah,
did you control for the district fixed effect?
yeah, it was fixed. We control for state fixed effects. Yeah. Yeah, we tried both actually, but we found that fixed effects were found. Of course, we didn't report there, but they were there. Yeah.
Thank you.
So you have a question.
Yeah. So what I've always found puzzling in the case of India is that citizens are not actively demanding help, which is why it has never become a political agenda. Right. And it needs to become a political agenda because, as Sir mentioned, that it's politicians, whatever he decides, that happens. right? So why is it the case? And I've been wondering because especially after COVID-19 and what people had to go through, they had to see a really tough time. Even after that, citizens are not actively demanding help. So is it because they have lost all hopes from the government and they think that government cannot actually serve them well? Or what is it?
Yeah.
I want to know that. Thank you.
Okay, I think we can
Maybe
answer
one
that.
last question and then you need to answer.
Yeah,
Can we stretch it? We're almost at 5.
yeah.
We give 5 to 10 minutes there.
Sorry, very quick question and very similar to what Ashi had said. I've always been under the impression that the government tends to put in money in more high visibility schemes. So ASHA workers will get money from the center and would be topped up with their honorarium would be topped up by the states as well. Whereas the government would not have so much incentive to build more mobile health units, both of which fall under NHM. Would it be then interesting to look at the split between revenue expenditure and capital expenditure and their constituents further deep to get a better understanding of where these transfers are moving from the center to the state, and then if the state is using them for capex or committed expenditure?
So a long list of.
Yeah. So let me first come to your question, capacity building. Of course, one of the objectives, as I mentioned in my presentation, also was to build capacity at the state level, and it has been happening. And this also relates to the question which you have raised. Like, not entire money in the case of NHM is being spent on wages and salaries. Part of it is going towards procuring medicines. Part of it is also going, maintaining and procuring, equipments. So that's the capital expenditure, but that's still very small. States like we showed Meghalaya and other, they are spending more than 15% even in NHM for wages and salary. Only Rajasthan, I think, spending just less than 1/3. So it has, but it's very little it is doing. So we need to do much more what we are doing. But again, the question is of resources. If you don't have resources, it's very difficult to, build your capital expenditure. How do you do that? Yeah. So I have no ready answer to this, but you need resources. Capacity building will require a lot of resources. So those resources are lacking. I don't know whether we have any other answer. And of course, they can, respond to supplement me if I missed out anything. Coming to your question of, not going to the hospital, I think it's not that people are, keen to go to private hospitals. People are forced to go to private hospitals because you find that there has been deterioration in quality of services in the government hospitals. And this also is the question which she has asked about the low expectations. Yeah, because people have very low expectations. So people beg, borrow, steal. If somebody has fallen ill in somebody's family, they will go to the best hospital which they can afford. So it's not a question of people are on their own volition, they are going to private hospital. I think they are forced. They used to have public hospitals used to have very good reputation at one time, and people used to prefer public hospitals. But now the trend has changed. I think it's I don't know whether Amarjeet Singh ji agree.
Slightly, but yeah, sorry.
Yeah.
No, just direction. In Goa, actually, it's reverse.
Yeah.
Primary healthcare is so good.
Yeah. No, in
It's
fact,
accessible all the time, and people prefer to go there. And it really worked during COVID at the time of the pandemic, because from vaccination to everything. So it gives a very good counterfactual.
In fact, Lavish, but 4 months ago, Ron Dres, Ritika Khera, and one more person, they have done a study for EPW on state of public systems of health in India. 5 states they have covered: Bihar, Jharkhand, Himachal Pradesh, Chhattisgarh, and Rajasthan. What is the finding? Himachal was already good, but further improvement in Himachal, because specialist doctors is a challenge, has not gone beyond a level. Chhattisgarh and Rajasthan have significantly improved in the last 15 years. Significantly. The allocation of resources, of public facilities and their total patient load has gone up 8 to 10 times as per that study. Bihar and Jharkhand, the improvements are sober, not so dramatic. whereas there was a requirement. So I think if I look at even independent studies, because very few get done these days, but this one in particular very clearly brought out this point that we did do something right in terms of overall approach to health. And Rajasthan and Chhattisgarh again are states which has a large state component and state leadership on health. They own the whole thing. Whatever they were doing, they were owning that.
No,
Competition effect happened in Rajasthan.
yeah, but it has to happen in all states. There is
No, I'm just giving that
Yeah.
example because
Rajiv was forced to scale it up. And given
Yeah,
the
you also raised question of efficiency. That's a separate issue altogether. Of course, we are trying to undertake study even on that too. Spending is one thing, but how efficiently you are spending, that's another thing. That study also we have taken up. We had don't
Yes,
have,
there's a lot of
yeah.
after education health is
yeah.
one which has the maximum.
So anyway, we have already, it's a 5-5.
So,
Thank you very much.
thank you.
Please
Thanks.
give them a big round of applause.
Thank you.
Huge applause.